Genu valgus is a condition in which the intermalleolar distance is increased. Normally it is about 4 to 5 centimeter in a child. If it is more than 10 centimeter, then you need to evaluate the child. The commonest cause is vitamin D deficiencies, renal or liver problems. If the distance is more, then you have to do a whole leg X-ray and measure certain angles like LDFA and MPTA. The commonest region involved is the distal end of the femur. Sometimes we have to do a 8-plate hemiepiphysiodesis to correct the deformity. We are going to show you a video of how to perform this 8-plate hemiepiphysiodesis. This is the clinical photo of the child showing genu valgus mainly on the right hand side. What you need to do is to take a scanogram and measure the lateral distal femoral angle. These are the instruments that you are going to need: an 8-plate, wire, screwdriver. So this is the incision. You mark the patella and it is usually on the medial side. This is the size of your incision, approximately 2.5 centimeter. You start with the skin and the subcutaneous tissues. So the next step is opening the capsule. You can see that I've held the capsule with my tooth forceps and I've picked it up. Just below the capsule you will get a leash of vessels which you may need to cauterize. So this plate mainly is intracapsular but extra periosteal. So now I am going to identify the physis. Usually it is at the upper level of the upper pole of the patella. I have identified it under C-arm. And now I am going to feed the plate. You can see that the plate is slightly bent. So you get these pre-bent plates. So I am going to feed the plate over my wire. So you have to put it under the capsule. Once you have done that, you will ensure the position of the plate under C-arm. And this is the time that I take a lateral view. So it depends on the position of the C-arm, and what you are going to need to do is that you are going to need to lift the leg. But if you place the C-arm oblique, then this is the view that you will get. So just to show you the clinical photo of what I mean. So if you keep the C-arm oblique parallel to the joint line, then you will get a different picture in lateral view. So I am going to pass the lower wire first. This is because this has to be very accurate. You cannot err in going lower or higher. And then you pass the upper wire. You confirm in C-arm that these two wires are parallel to each other in both planes, in AP as well as the lateral plane. I put them slightly longer so that these wires don't come out when I remove my drill. So again I am going to put the lower screw first. I have drilled it with a 4 mm drill bit and putting a 4 mm cannulated screw. So this is the picture. Position looks good. And now I am going to put the screw in the upper hole. Now I am going to remove the wires. And check it in AP and lateral view again.
So this is the lateral view, and this is the lateral view again if I keep my C-arm oblique, that is parallel to the joint line. Important thing over here is closure of the capsule. You must close the capsule properly. This is followed by subacute and skin closure. I usually choose a 3O monocryl for the skin, and I put simple stitches. This is because we are going to start knee range of motion and we don't want the skin sutures to give way. This is the final scar at the end of surgery. So the protocol post-operative will be that you start knee range of motion from day 1 and standing from day 2.